Welcome to the If So podcast. This podcast is sponsored by WeightWorks Clinics, the Netherlands.
Hello, this is Jacques Pauls. I'm a surgical resident in Detmold in Germany. And welcome to the next If So European chapter podcast on pharmacological considerations before and after metabolic and bariatric surgery. I'm here with Dr. Carmel Azran from Israel. She's a clinical pharmacist, healthcare executive, clinical researcher, and regulatory expert. She's led multiple complex operations in hospitals and HMOs, specializing in quality management, medical technology assessment, and clinical pharmacy. Currently, she serves as a director of medical technology department at the Maccabi Healthcare Services, is an assistant professor at the Hebrew University in Jerusalem School of Pharmacy, and is a clinical pharmacist at the obesity clinic HMC Hospital in Israel, where she treats patients with obesity and polypharmacy. Dr. Azran is a recognized clinician specializing in obesity and bariatric surgery with over 27 publications and contributions to national and international guidelines. One of the recent acknowledgments is that she serves at the Israeli National Health Basket Subcommittee, which approves every drug or technology for citizens in Israel through the National Healthcare Insurance. She's the chair of the Clinical Pharmacy Association in Israel. The perfect guest on our podcast to talk about pharmacological considerations and every aspect of a topic that not many surgeons know a lot about. Hello, Carmel. Welcome to the If So European Chapter podcast. First, a simple question. How are you doing today?
I'm doing really good. Venice is really nice, and thank you for having me. I'm excited to talk about this topic.
Yeah, and then I'll open with the elephant in the room, the most important question. You're a clinical pharmacist in a bariatric team. What do you exactly do on a daily basis? Can you explain us that?
So that's actually a really good question. Mostly what I do is I see patients before surgery. That's most of the patients. Some patients I see also during hospitalization and after, but the majority would be before surgery. And my job is to advise patients and their healthcare provider about their medication regimen. Mostly their chronic meds, like their diabetes medication, psychiatric medication, hypertension medication, and I tell them which medications to stop, maybe change of formulation, which one would we continue. I also give their primary care provider instructions into which labs patients should get before surgery, which prescriptions they should have. This is all so they can be really, really prepared for surgery. And this is all to prevent complications. Actually, in a recent study that I was able to publish on my patients, I saw that these consultations were able to prevent hospitalization after the surgery. And this was compared to a control group. So we know these consultations can work and can prevent complications. And that because many patients might have absorption issues after the surgery because their gut is all changed. We bypass a lot of the times, we bypass their intestine, which is the site of absorption of medications. And so we actually have to think about that and think how we change the regimen before surgery so they don't get complications like have their psychiatric condition get out of control or have their diabetes get out of control or epilepsy or all these chronic conditions they come to surgery with. So basically, every patient that comes to my clinic gets a letter that goes to them, but also to their primary care provider. And with that, they have instructions and they know exactly what to do with each one of their medications and what to monitor. And the most important thing about bariatric surgery and medications is monitoring. If there's one thing about this podcast people should think and remember is monitor, monitor, monitor.
Okay, that's a good take-home message, and we're only 5 minutes in. You talked about a few common medications. You anti-epileptics, psychiatric medication. Most of the bariatric teams I know don't have a clinical pharmacist or a pharmacist or a pharmacologist in their team. What do you advise surgeons that don't have a pharmacologist in their team? What should they really know about medication?
So I would say the most important thing to know first is that most medications will change after surgery. So knowing that you cannot just continue the exact regimen that person came to surgery with in the same manner. So even if you don't have a pharmacist, you have to go and look at the literature. You have to go and consult even other healthcare providers, or maybe I have people contact me from all over Israel, even if they don't work in my hospital. And this is because I think it's always better to ask and not just give people medications that can give them complications. And so I would say, first of all, just know medications are not the same before and after surgery. The clinical studies on medications do not check a gut that had bariatric surgery. We don't know what is going to happen. The pharmacokinetic changes, the pharmacodynamics. And so that's the most important thing to know. Just know there are going to be changes in absorption. And of course, we know that other changes happen, like the diabetes might resolve, and someone needs to give those instructions to patients. And so just make sure that you do consult with someone if you can. Also, I would be most careful with medications that have a narrow therapeutic index, meaning those medications that we check blood levels for, because we know those might be affected. For example, lithium, we know that we might have severe toxicity, and this might happen in sleeve gastrectomy, in bypass, any kind of bariatric surgery. And so you have to monitor. This goes back to what I said before. You always have to monitor. And so for those medications that you can check blood levels for, always check blood levels. Even if you're a surgeon, you can ask, which ones do I have? In some medications, we have blood levels. It's not the common ones, but we still have them. So request for that. Even, for example, for anticoagulants like apixaban, it's not maybe common to check blood levels like anti-10A, but we would do that for bariatric patients. The same for epilepsy drugs. So it might not be the common blood labs, but you still do it for these patients. So whatever you can, send blood before surgery and then after, because we always want to know what is the baseline of the patient. It's not enough to know after. If it's a psychiatric patient, let's say taking, for example, carbamazepine, if we don't have a baseline lab, we have nothing to compare and know if the surgery did any impact on the medication. So it has to be before and after the surgery. Also, there's one thing that sometimes I have issues with surgeons, which is crushing the medications. And what they say is patients can swallow. They don't have any problem swallowing after bypass surgery. And the thing is, the reason we ask to crush medication or change to a chewable form or syrup is not because they can't swallow. It's because it helps the absorption of the medication. We know that most absorption issues happen in the first 2-3 months of surgery. Some medication we will see it a year after surgery. But we know that mostly it's the first couple of months because the stomach is still very kind of tight. It doesn't have the same motility. And for pills to break and disintegrate, which is the most important step in absorption, the disintegration, it needs the stomach to have that ability to do like motility and crush medications. This is why we also give them nutrition, right? At the beginning, you give them liquid nutrition, and then you give them like yogurts. It's the same with the medication. So crushing the medication, it's not because of swallowing, it's because of absorption. And for some people, it can be critical. We see this in research. We see that if you crush a medication for a bariatric patient compared to not, you will see different levels. And we see it in different medications all over, even like PPIs, which we give all patients after surgery, right? You give them, right? You give them like Nexium, or we see a big difference if you open the capsule or you dissolve it, depending on which medication you give. There are research showing that people that take it that way, actually, if they have a marginal ulcer, it will heal faster in this way compared to giving it intact. So we know this matters.
And you're talking about a soluble form or
exactly
of a PPI.
Exactly.
Compared to a tablet or a capsule.
Right. There was a study looking endoscopically at people with marginal ulcers, and they had two groups. One got intact capsules, and the other got this soluble form. And one group healed after 340 days, and the other group with the soluble form healed after 90 days. And this was the only change. Nothing else was significant. Not smoking, not H. pylori, not NSAIDs, nothing. Only the change in the formulation. And so there's a reason we say that. It's not like we're trying to give the patient a hard time. We're trying to help them with their medications.
It basically has a physiological basis.
Right. And the last thing we have to remember, the worst or the most effect we see is with bypass surgeries, right? Malabsorptive. Because we have two effects there. We affect the stomach, we make the stomach small, but we also bypass the site of absorption of medication. Okay, so the most effect we do see this in studies would be with malabsorptive procedures. But it doesn't mean we don't have that in sleeve. We see effects in sleeve as well. Even though we don't bypass, we still see that the effect on the stomach still is can be very significant on medications. And so the fact that if someone is doing a sleeve probably would be better, and I might choose this for certain medications, like if it's a very important medication, I might prefer to do a sleeve to this patient and not a bypass, if I don't want them to kind of not absorb the medication. But still, we have to be careful with sleeve as well.
So basically you're telling me that you're also involved in critical decision making. Yes. In the decision for a certain type of surgery or not, based on their own polypharmacy, basically, right, on their chronic conditions.
I think I would say that about 50% of the patients I see in my clinic are actually referred to me by the surgeons asking me, should I choose one type of surgery over the other? Is the medication the patient is taking critical with the type of surgery I do? Or let's say there's like a high BMI patient and they really want to do a bypass for this patient. They're like, can we deal with the medications after the surgery? Or do I have to do a sleeve? So we do have that conversation. And unfortunately, the data is really scarce. We don't have a lot of big studies. A lot of even studies I publish is like very small, not a lot of patients, because we're not able to get these like really big studies. But we have enough to kind of know where we think things will go after surgery. And this is why a clinical pharmacist is so important in these decisions, because you don't want your patients to get complications, and we're doing the surgery for them to get better. But if you're worsening their chronic conditions, you did nothing with the surgery, right? Because if the patient is now hospitalized because of their psychiatric condition, or out of control with their other diseases, then they're not going to be happy with the surgery, right? So that's why it's really important.
That's true. We need to be aware of the fact that we don't change one chronic condition for a problem with another chronic condition. One question. You briefly mentioned some concepts like pharmacodynamics and pharmacokinetics. Can you briefly explain for the listeners who do not know this, what's the difference? What is pharmacodynamics? What is pharmacokinetics?
Sure. So pharmacokinetics is actually what is the body doing to the drug, okay? Mm-hmm. And pharmacodynamics is what is the drug doing to the body. So pharmacokinetics is basically when you take a drug, there's like an acronym, it's called ADME, which is absorption, distribution, metabolism, and excretion. So pharmacokinetics is basically what happens to the drug in our body. How is it absorbed? How is it distributed? Okay, is it the blood? Is it the fat? How is it metabolized? Is it metabolized by enzymes in the liver, in the gut, okay? And excretion, how is it excreted? In the through renal, or... and so this is pharmacokinetics. So a lot of the times bariatric surgery can affect the pharmacokinetics, because if we change absorption, we can change metabolism by bypassing, right? We have a lot of enzymes in the intestine. And if we bypass those enzymes, the CYP enzymes, right? Those CYP3A4, which is like the main one and it sits in the gut, then if you bypass that, you can actually increase absorption of certain medications. And so this is why we have to think about all these different pharmacokinetic factors with our medications, and we do that. We do that when we don't have data. We look pharmacologically. What is the logic telling me? What is going to happen with this medication?
And what about pharmacodynamics then?
So again, a lot of times when you change the pharmacokinetics, you affect the pharmacodynamics, right? For example, if you have more absorption of medication, let's say warfarin, right, which is a blood thinner, if the absorption increases after surgery, and we see this, right? So for warfarin, you have to decrease the dose in about 20% after surgery. So the effect would be increase of blood thinning, right? So this is the pharmacodynamics. The pharmacodynamics is the blood thinning. It's the headache. It's what do I see as the effect of the medication. So it actually affects one another, right?
Yeah. So but these are the core concepts in clinical pharmacology, right?
Right. Of course. So if I have a medication which I don't have any data on, I will go and look, where is it absorbed? How is it metabolized? What do I expect the surgery to do? Right? So let's say there's a medication that is affected by acid, stomach acid. Now I know I'm affecting it. Then I expect the surgery to change the absorption, maybe increase, maybe decrease, right? Depending on what type of medication. So for example, for lithium, we think the reason we get toxicity is because of the stomach acid. But every drug is totally different, okay? And we also know, it's very interesting that actually the intestine develops some kind of adaptation to the surgery. This is why a lot of times we see patients affected in the first 6 months after surgery, and then all of a sudden you see their blood levels go back to normal 6 months later, or like in 12 months after surgery. There's some kind of adaptation of the intestine. We see, for example, those enzymes we're talking about, sometimes you see them further down in the intestine all of a sudden. They were not there before. So we have all these changes in our gut that can affect the absorption of medication. So, yeah.
And from a practical standpoint, how does your follow-up scheme post-operatively look like? How often do people with really, let's say, a chronic condition with these kind of polypharmacy, how often do you see those patients after surgery? And do you have some sort of protocol, tips and tricks for our colleagues around the world, how we should do it and how do you do it?
Yeah. So like I said in the beginning, I think the most important time to see a patient is before surgery, because at that point you can still have the effect on maybe choosing the right type of medication. If they need to get some kind of blood labs, for example, for drug levels, then this is a good time to do it. And also a patient, you can actually sit down with them and have them like a calm conversation and explain to them, this is what you should expect from the surgery. You might have a change with your medication. You should know. This is something they need to be aware of. If this can affect their psychiatric condition, they need to know. They need to know what to follow. They need to know how to self-monitor. I always tell them to keep diaries. For example, a diabetes diary. You have to check your blood levels every morning, your blood glucose, and then this is how you change your medication. Same for hypertension. Same for Ritalin, which can be affected by by the surgery, and a lot of times I have to tell them, you go and check how long is it working for you before surgery, and how long is it working for you after surgery, and then we think what to do. How do we change their medications? And so there are many factors we talk about, but I think definitely preparing the patient, telling them the truth. I always tell them the truth. You should know this can change. You have to see your psychiatrist. You have to see your healthcare provider. If you don't think you can do good monitoring, you can get complications with the medications. And it doesn't make them not want to do the surgery. They feel much more comfortable when they go to surgery that they know what's going to happen. So I think this is the best time to see the patients. And then after the surgery, I would say, since there can be all these changes to the medications, you want to see them sometime in the first 3 months. Okay, I would say 3 months is a good time, because by then we would know if something changed with the medication. Do we have to change doses? Do we have to like maybe switch a medication? So I would say these 2 points are important. And of course, if someone is getting complications or starting a new medication like after surgery, then that's like as needed basis. It's not like something I would say you have to do that. So this is kind of like the time points that are most important. And as for good tips, I think like I said, getting the patient prepared before surgery, that's probably the best tip I can give, because when they are getting the consultation after surgery, a lot of times it's just way too late. And it's really hard by that time to correct it. I've had patients that I consulted, I didn't see before surgery, and after surgery they got complications like psychiatric conditions where they had to be hospitalized, and then we had to like start chasing the medications. Or I had patients come to me with intracranial bleeds with warfarin that was INR 12, and this was way too late. Like they were not well prepared. And so this would be the best tip I can give.
Like surgeons, we like to keep it practical, especially since not a lot of teams have a pharmacist or a pharmacologist. My own experience, especially with antihypertensives, with anti-diabetic drugs like metformin or other types, are like, okay, the patient had surgery, irrespective, sleeve, bypass, one anastomosis. When do I stop those medications? When do I stop my metformin? When do I stop my ACE inhibitor in terms of hypertension? Do you have any tips for surgeons on the planet who do not have access to a well-known clinical pharmacist? How should we do that?
Well, I want to say, and I told you this before the podcast, I'm actually working on trying to get some kind of maybe a WhatsApp group or like a Facebook group where surgeons or any healthcare provider that has questions about medications can come to us, the ones that do deal with it every day, and ask us questions so we can help, right? So I do this in my country where people do ask me from all over, but I think this is something we should do internationally to help patients and not just wait for the team to get a clinical. Of course, it's the best if you have your own, but I am trying to have that availability for all the surgeons to actually, if we need to, then contact me or other clinical pharmacists. So this is something we're working on, but I wish my answer was easy. It's just, it depends on the medication. So every medication we deal with differently. For example, metformin, for example, we won't give it like a day or two before surgery, right? But we do actually reinitiate it when people start swallowing and when they're discharged home. So for example, my diabetes protocol is they check their blood sugars in the morning. And I'm not talking about like the heavy diabetic patients that are injecting insulin. This is like the ones that we think their diabetes will resolve, right? We know that a lot of them do. Yeah, so I tell them, you check your blood sugar every morning. If it's more than 120, you take one metformin crushed with breakfast. If it's less than 120, you take nothing. And you have to keep this diary and bring it to your primary care doctor 2 weeks after surgery, so we see what happens to your blood sugars, because I'm not going to live with them and see what happens, right? So I have to give them a protocol. And I do the same actually with insulin. So for example, if it's a long-acting insulin, I do give them a sliding scale. What we usually don't do with regular patients, we only give a sliding scale for the short-acting insulin. But in this case, we give a sliding scale for long-acting insulin because we don't know where their sugars are going to be. So I tell them, if your blood sugar, let's say, again, it depends how they came. Let's say your blood sugar is 180 to 250, then you inject 10 units. If it's 250 to 300, you inject 14 units, okay? Again, depending how they came and how many they injected before. So I give them a sliding scale, and that's how they know how to monitor their new diabetes, because it's not the same diabetes they had before. Everything changed. For hypertension, we stop all diuretics. We don't continue even the thiazides. We don't continue them because we know they have an effect. And of course, we don't want them to have kidney injury. And so we stop them and we don't continue, definitely not at the beginning when they can't drink enough. We have an exception again, of course, for CHF, for furosemide, but I'm not going to get into that. But I would say as a rule, we don't continue diuretics. ACE inhibitors, we stop 24 to 48 hours before surgery, again, because of the risk of the kidney injury. But once they're back, they're drinking, I do continue it, especially if they have heart conditions, especially, of course, the more complicated patients. And so, again, aspirin, we don't stop. We used to stop or give PPIs for life with aspirin. We don't do that anymore. We give baby aspirin. We don't crush it, okay? We keep it with the enteric-coated. And then we continue that. There is research showing that it's okay, and it doesn't increase the risk of marginal ulcers, unlike NSAIDs, which, of course, we stop for life. Birth control, we stop for sleeve and bypass. We don't give oral birth control anymore. We change them to IUDs or to NuvaRing. No more birth control. We've seen too many unplanned pregnancies, and we just don't give that anymore. So we have to tell them this before surgery, right? Also, they have to stop the birth control 3 weeks before surgery and 3 weeks after. We don't give hormones, right? We don't want them to get DVTs. And so all these things are, this is endless. You can ask me, I can have like 200 examples. It's way too much. But again, for the chronic conditions, like the main things, and of course, extended release formulations, these are a big problem. You can't crush them. And so usually for sleeve gastrectomies, I will continue them. But of course, for bypass, I cannot. And if I have to, and I don't have another option, then we have to educate patients. Tell them, most likely it will affect your absorption. You might have to increase doses. So we monitor, and then we decide what to do. And so this is kind of like, I would say, the big things to think about. But of course, we can't get into every medication.
Yeah, then the podcast will take a few hours more.
Yeah, exactly. I teach 3 hours of just this in the university. So
one final word, one final thing I would like to discuss is you're a very active researcher also. Interesting thoughts on the pharmacology hotline. So hopefully after this podcast, your phone will be starting ringing. What's your take on the clinical pharmacological research in bariatric surgery? What is there and what is missing? And how are you going to try to change that in the future?
So I'm already trying to change that as much as I can. And I think more and more people are trying to get involved. The one thing we are going to try to actually send through IFSO, I hope sometime in the next few months, is just going to be like a guideline with tables and just every medication, what are you expecting to happen? So it's going to be a lot of medications that are problematic, and it's just going to be a guide for surgeons where they can just choose the medication and see, oh, okay, this is going to increase in sleeve or decrease in sleeve. This is what I need to monitor. This is the blood levels I expect. So it's going to be like a very, very practical guideline for everyone. This is because we know clinical pharmacists don't exist a lot. And so I really try to kind of make something for the surgeons to guide them. I do a lot of research right now. I have a new publication that's going to be coming on carbamazepine. It's going to be the biggest study that is publicized. It's only 27 patients, but this is the biggest one there is because this is what we could find. We looked back for 10 years in my HMO, and this is what we could find, 27 patients. And the reason we could not find more patients is because the one thing that people don't send them to get their blood labs. And so I was trying to get lamotrigine patients. I just didn't have data because they're not sending them to get labs. And so this is a problem. So the more we have people sent to get labs and to clinical pharmacists, the more research we can publish. I have a big meta-analysis that I published about levothyroxine. And what we found there was actually very interesting, is that subclinical hypothyroidism was resolved after surgery. So people actually, one of the things we talk about diabetes that is being resolved, but subclinical hypothyroidism for most patients will resolve after surgery. And we also saw that you have to decrease the dose of levothyroxine by about 15 micrograms per day. And I think there's a lot more to research. We want to do more research about oncology, which is difficult, and more about the anticoagulants, which there is research, but again, very small amount of patients. And there's a lot more in psychiatry that is missing. We don't really have good research about the antipsychotics like Zyprexa or, all these kind of, so it's a lot of the questions we get and we don't have research to rely on. So I try to do a lot of it. And of course, any kind of collaboration or people that are getting or looking to get into this field, that would be great because, again, there's I do work with another clinical pharmacist from England, but there's just not enough of us. So I think collaboration with surgeons and just thinking together how we can kind of find these patients and just have a guideline for others to monitor, I think that would be very helpful.
So that's another reason to that your phone will start ringing in the coming months. Carmel, I would like to thank you for being our guest on the podcast. Any final words for our listeners?
I think we're doing great things when we give patients bariatric surgery. I think it's a big gift. I think it's life-saving. When people ask me, should I get the bariatric surgery, I always say, and it's going to be maybe bad to say, you don't see a lot of 80-year-olds with obesity because they don't last that long. We actually, when you give them that surgery, you save lives. But we have to make sure that in the process, we see our patients as individuals with all their conditions they come with, all their medications, and we want to make sure we're not making it worse. And so I would like to say that even though we're doing really great things with the surgery, we always have to think about all the other stuff people are going through, if it's nutrition or, their psychological conditions, but also their medications, because sometimes that could be a big factor. And I have patients that have come to me and say, I lost all this weight, but I wish I didn't do the surgery because it ruined, now I can't deal with my medications. And so preparing the patient is really important. So you see these patients with medications or conditions that can be worsened, don't hesitate to get a consultation or get them ready. This is one aspect, like you said, most places don't have it, but it could be a really important aspect for them.
Yeah. That's a wonderful take-home message. I would like to thank all the listeners and stay tuned for the Pharmacology hotline, soon to be coming online, a Facebook group, and of course for our next podcast. Thank you very much.
This podcast was sponsored by WeightWorks Clinics, the Netherlands. Thank you all for listening.